I have the privilege to invite Dr. Manish Mahendra today. He will be enlightening us on how the wrong choice of IOL can give us an unhappy patient in the post-op period in our OPD. He is a renowned, internationally recognized anterior segment surgeon. He is medical director of Khairabad Eye Hospital, Kanpur, and has to his credit of presenting in prestigious conferences like ASCRS, ESCRS, and many instruction courses in AIOC. So we are happy to have you here, sir. Please carry on with your presentation.
Thank you, Mohit. Very good afternoon to all of you. And it's a privilege to be a part of this IC and a privilege to be with such stalwarts, especially Dr. A.K. Grover sir, Dr. Suhas Aldiprakar sir. And looking at those videos of Dr. Suhas, it reminded me of my good old days when I was doing my fellowship there. And he used to operate and manage those complicated cases so beautifully, so meticulously. So, he's an excellent surgeon. So, now moving on to my topic, I will be talking on the wrong choice of IOL. And I'll be showing you a couple of my cases where I put implanted the wrong IOL, and we'll discuss about what all things we should do to avoid all such errors. So this was a case of a 35-year-old male. He had an history of retinitis pigmentosa with a nuclear sclerosis of grade 2+ with a posterior subcapsular cataract. We did an uneventful phacoemulsification and implanted a hydrophilic lens in the bag. And what happened? This patient comes to me after 4 years, and this is what I see. There is an anterior dislocation of the IOL back complex, and you can see the IOL sitting there in the anterior chamber. So what went wrong here? Now, as we all know, these retinitis pigmentosa patients have a progressive zonulopathy. They have weak zonules. So capsular phimosis occurs in these cases because of unopposed capsular bag fibrosis, which leads to later on an IOL subluxation or a dislocation which can be anterior or posterior. So this is the video. As you can see here, the IOL bag is sitting there in the anterior chamber. So I enlarged my incision and I pulled this IOL bag complex out, and you can see how the bag is entangled to the lens. So now I am gently removing the bag from this entangled IOL, and you can see here, you can appreciate the amount of phimosis which is there. There's a shrunken bag. This was followed by an anterior vitrectomy, and then an AC IOL was implanted. You can go and implant and do a scleral fixation IOL, or you can do a glued IOL or a posterior iris claw IOL. So what went wrong here? Wrong choice of IOL. We implanted a hydrophilic lens. Hydrophilic lenses are good. They had single piece acrylic lens. They are easy to implant. They avoid additional stress on the zonules. But at the same time, they don't resist the capsular contraction. And therefore, in this particular case, for these cases, we should have implanted a 3-piece IOL, which would have been a better choice. They are more rigid. They resist capsular contraction and therefore prevent capsular phimosis. This was another case of a 36-year-old male, had a posterior subcapsular cataract with a compound myopic astigmatism with high K values. We did a biometry and implanted a toric IOL here. And what went wrong here? We were actually dealing with the keratoconus patient, and as we all know, to calculate the IOL power and to do a proper selection of an IOL is a big challenge here. These keratoconic patients have a high amount of irregular astigmatism. So putting a toric IOL is good as long as we are dealing with a regular astigmatism or a mild to moderate keratoconus, but if it's on the the keratoconus is slightly advanced, then you should avoid these lenses. Visual axis is not at the apex of the cornea. As we all know, it's on the slope of the cornea, and therefore we get artificially high K values, and therefore the calculation power can go wrong. So how do we even know that we are dealing with an irregular astigmatic case? When you do your biometry, when you do your IOL master, it's important to look at the standard deviation values, and if these values are more than 0.2 diopters, which is expressed as 0.03 millimeter, then you should think that there's something wrong here. We might be dealing with the case. We are dealing with the case of irregular astigmatism, and we should further investigate these cases. Do a corneal topography, do a pentagram, and then put a proper IOL. This was another case of a myotic pupil of a 76-year-old male who had a mature cataract with a senile myotic pupil. He wanted trifocal lenses, and we said, okay, we'll go ahead, and we did an uneventful phacoemulsification and implanted a trifocal IOL. And this patient comes to me after a week's period complaining that his near vision is compromised, and he's very disturbed. So now what happened here? If you look at the trifocal lens, now they have a central refractive zone with the diffractive zones in the mid and the peripheral areas. So when we implanted this lens, now the whole iris actually covered the diffractive zones, and only the central diffractive zone was left, which was there for the distance vision, and therefore his near vision and the intermediate vision got compromised, and that is why he had this difficulty. So in this particular case, we should have actually implanted a monofocal lens. This was another case of a 52-year-old male who had undergone LASIK surgery 18 years back with a nuclear sclerosis of grade 3. We did a biometry, looked at the fundus, everything was normal, and we just implanted this IOL power of 15 diopter, which we got. And this is what happened. There was a post-operative refractive surprise, a post-operative hyperopia. Vision unaided was 660, which improved to 6.6, but with the refraction of a +3 diopter, and the patient was extremely unhappy. So what happened here? Now we all know that after we do an excimer laser, the anterior corneal surface changes, but the posterior corneal surface remains unaltered. So there is a change. There is a change in the anterior posterior power, change in the anterior posterior ratio, and which alters the keratometric refractive index. And this is in relation to the amount of the laser that we apply. So that is how the power, the K values get altered. So after myopic correction, the keratometry readings usually overestimate the corneal power, and therefore the IOL power is underestimated, and that's when we get this post-operative hyperopia. So what should we do here? We should try to retrieve all the pre-operative data that we can get on, analyze the corneal map. If you have ray tracing devices, that's very good to know the corneal asphericity, the posterior corneal astigmatism, the corneal aberrations, and always under-promise these patients. When you under-promise these patients, then only you can over-deliver. So this is the post-operative IOL calculator that we can all get through the ASCRS website, and here if you look, you have to put in all the data, the pre-LASIK refractive error, the keratometric values, the post-LASIK refraction, the topography, the CCT, the ACD, the excellence, everything that is there, whatever you can get hand on, whatever data you can get, you should input it here, and then you will get an estimated IOL power, and that's where you can go relatively, you won't go wrong here. This was another case, an uneventful phacoemulsification was performed, and a PCR occurred. We did a proper anterior vitrectomy and implanted a single piece acrylic lens. And after a month's period, we see this patient, the IOL is decentered. So what happened here? It's whenever you get a PCR, you should always try to avoid these single piece acrylic lenses, because the haptics can scratch on the posterior pigment epithelium of the iris, thereby releasing pigments, causing uveitis, which can lead to secondary glaucoma and all sorts of complications. So ideally we should have implanted a 3-piece here. Now these lenses are slightly larger in size, they fit in very well in the sulcus, and their haptics are angulated in such a manner so that the optics are slightly away from it, and they don't rub against the posterior pigmented epithelium of the iris. So therefore this should have been the right choice. Another interesting case of a 42-year-old male myope with a nuclear sclerosis of grade 2 had a refractive error of -2 diopter prior to cataract surgery, and we did a biometry, implanted a monofocal intraocular lens, and I thought everything had gone right, but the patient was absolutely miserable after surgery. So what actually happened here? There was complete loss of accommodation, that we all know. Despite an unaided vision of 6.6 and a good near vision of N6 with a +2.5, still the patient was complaining. And when we said that, you got good vision for distance vision, it's only for near that you have to use glasses. He said that, I've never been using glasses for near. All my life I've been using glasses for distance. And now you've done the reverse. You're asking me to wear glasses for near. So the message is that you should treat a specific patient according to their need and provide the best possible vision here. When you're dealing with these moderate myopic patients, you should overcorrect the IOL power and make them slightly myopic. When you make them slightly myopic, they're quite happy, because for near they are comfortable using they are comfortable without glasses, and even if they have to wear glasses for distance, they don't mind it because they've been doing it for years. So that should have been the choice. Presbyopia correcting IOLs is a good option here, and you should always explain the pros and cons to the patient. A very important thing to mention here is that whenever we are implanting a trifocal lens, you should always think, look at the angle kappa. Now, what is angle kappa? Angle kappa is basically because the IOL should be right there in the center at the angle kappa, which is the distance between the center of the pupil and the visual axis. So what is this? So if you look here, if you see the diagram here, you will see there are 3 dots. You see there is one green dot, the blue dot, and the yellow dot. Now the green dot is the optical center, which is actually the center from the nasal and the temporal limbus. So that is the optical center. Now you have the pupil center, which is the blue dot, which is the center of the pupil, and the yellow dot, which is the visual axis, which is the line drawn from the fixation point to the fovea. And your lens should be right here in the center, somewhere between the visual axis and the center of the pupil. I'll show this diagrammatically. If you look here, now if you see here the fixation light and the line drawn, which is this yellow line, which falls on the fovea. Now this is the visual axis. The green line which is passing through the optical center is the optical axis, and the blue line which is passing through the blue dot is the pupillary axis. And this angle kappa, this is the angle kappa which is between the pupillary axis and the visual axis. Angle alpha is the angle between the optical axis and the visual axis. So you have to look at this angle kappa, where the lens should be right there in the middle. So if you look at this surgery, you see there are the Purkinje images, the anterior and the Purkinje image, they should fuse at the end of the surgery, and that's when we know that our lens is well centered in the middle. Now, how do we know that the particular patient is suitable for a trifocal lens, or whether we'll get halos or glare or not? Now, this you can know by doing an IOL master. When you do the IOL master, you look at the values which are right below the white to white values, that is the chord mu, and you see you have these px and the py values. Now, when you add up these values, it should be less than 0.6 millimeter. If the values are more than 0.6 millimeter, then the patient is likely to have halos and glare. And if it's less than 0.6 millimeter, that means the patient is likely to get his IOL well centered, provided all the other things are, you have a central rexis and everything you have a proper surgery. So if it's less than 0.6 mm, then you can go ahead and do a trifocal lens implantation here. So to conclude, a thorough pre-surgical evaluation is must in all our cases. With careful surgical planning and skillful and diligent surgical technique, you will get good outcomes and will have good results. And choosing a proper IOL is of paramount importance. It's very important to choose an IOL. You should have a good inventory with you, and whenever you land up into any problem, any mishap occurs, you can always go and put the right IOL. Thank you.
Thank you, Dr. Manish. That was really very, very informative. And now we have been waiting for this presentation. We have Dr. A.K. Grover sir here with us. He needs no word of introduction. He has been awarded Padma Shri. He was the president of AIOC. He's chairman of Sir Gangaram Hospital and teacher of teachers, I would say. So even after good OPD work, good surgical skills, good choice of IOL, good biometry, still we can have an unhappy patient. So now what is left? So let's explore what more is possible, and that nobody better than Grover sir can tell us that how can we prevent such things happening in our OPD, and how can we have most of the patients happy.
Thank you, Mohit. wonderful to be a part of this beautiful course.